Hi, I'm Allison Woodhead. I'm the clinical lead for prisons working for Notts Healthcare for the NHS. And it's just been a brilliant opportunity to work with this group of people, because we are, for the first time, kind of really trying to think about the kind of multiple disadvantages. So when I came into my post to develop pathways in prisons, the first thing I was aware of was that we wouldn't just be talking about neurodivergence, we would be talking about how that sat in relation to experiences of trauma and all sorts of other stuff. So it's been really, really useful to, and people being released homeless and, you know, all of the kind of multiple factors. So I think it's been really, really useful working together. And I wanted to just talk to you about the way in which we've gone about developing pathways in prisons, where we've got, how we got started, you know, what we're talking about really in terms of what we've been doing. So, oops, hold on a second, already making an error. Okay, so just in terms of our prisons, so that you know where we're providing a service, Notts Healthcare has got contracts in prisons all over the East Midlands, and so we've got HMP Ramsey, Nottingham, Morton Hall, Loudon Grange. Morton Hall borders on, I don't know if it falls into Notts or Links, but they're all Notts prisons. Then we've got HMP Lincoln, we've got HMP Fossway, and we've got HMP North Sea Camp. And just to kind of explain the breadth of kind of population that this kind of covers, just from a prison perspective, that means that we've got 3 remand prisons, we've got 2 resettlement prisons, which are prisons where people stay a little bit longer, they're sentenced and they come into prison to serve that bit of their sentence. And then we've got Cat D prison at North Sea Camp, which is a prison where it's an open prison, so people are going in and out to work. It's a very different kind of setup. And Loudon Grange is for kind of, it's a Cat B for sentenced prisoners. They can stay up 10 years, you know, long sentences, so definitely longer than a kind of short sentence. So we really are spanning the difference between a remand prison, which means that people are coming in unsentenced, waiting for their court appearance, and they may go somewhere else when they have been sentenced. So that can be a really short stay in a prison like HMP Nottingham or Lincoln. Or they could stay a bit longer. And that has meant that designing a pathway for people coming in and out of prison has been really difficult, because sometimes we're in a situation where we're going to know somebody for 6 weeks or 12 weeks and no longer. Sometimes we're going to be able to work with somebody for a really long time. And it was a challenge in terms of how to work out what we did in order to make that work across the prison system, because we wanted it to be equitable, but also practical for all the different prison kind of populations that we serve. Okay, so just in terms of who we are and how we came about, just so that you can kind of understand how we got to where we got. I have actually sort of lost track of when I took my job. I think it was 21. It was on the end of COVID time. I think I'm approaching 3.5, 4 years this year, but I have sort of lost. I keep saying it's a brand new job and then realizing it's not anymore. But when I was employed, it was because our clinical director for Notts Healthcare had a bit of a passion for neurodiversity. He'd got a son with ADHD. He had been working in prisons a long time. He'd been prescribing for people with ADHD, feeling like, despite the fact that there were no pathways in the community, that he recognised that potentially people had missed diagnosis and treatment, particularly around ADHD, from his perspective. And that he was seeing good outcomes for people who finally were diagnosed and treated. He was seeing differences in how people were able to cope, both in prison, but he was hopeful that some of the kind of impulsive traits, and that it might be kind of trying to help with reoffending and people's kind of emotional management of themselves. So he was quite passionate. He went out for a job for a clinical lead, and at that time there was just nobody else doing it at all. So when I first came into post, I couldn't find any equivalent anywhere. There have since been a few clinical lead roles pop up in private prisons and all sorts of, you know, different versions of, but still quite new. And the idea of having a clinical lead, so that instead of each prison developing its own pathway, which is a more traditional way of prisons designing, you know, the work that they do, and it meant that we were able to look at the whole thing across multiple prisons and multiple people and to try and get something that would work consistently. This had a massive advantage as well for our local prisoners because often they transfer between prisons. So we've got somebody who might start their journey in an HMP Nottingham remand setting, but transfer to Ramby for the next bit of their sentence. And if we hadn't have looked at a pathway the way that we have, it would mean that every time they moved, they started again, or they went to a prison where there wasn't a pathway. So in my mind, I had considering what would happen when people left prison as my first priority, because being in prison is a short period in anybody's life, even if you've got a longer sentence, and we shouldn't really be focused on just life in prison. So I was trying to think about what we could do that would make a difference when people left us. But I was also trying to think about continuity of care between prisons and the massive frustrations that people have of retelling their life stories 1,000 times and restarting assessment processes 1,000 times. So I was wanting us to kind of get into a system where we could be realistic, but start our assessment process and continue it between ourselves. So I'm the clinical lead, and I started by trying to make sure that we'd got somebody in each of those prisons who could do some of this work. And how that looked at the start was that we'd got learning disability nurses. They were called IDD nurses, intellectual developmental disorders nurses, and they were all of a learning disability background, and they were all nurses. They still are all nurses, despite the fact that all our jobs go out as a band 6 AHP, allied health professional or nurse option. So we could have OTs or speech therapists, but so far we've always had nurses apply. So I had a few of those in post in a few of the prisons, and the people that were in post had got perhaps 2 days doing the job, or some of them had got 3 days doing the job max. Some had got less, and some had got nobody. So the first job was to look at equitable offer and to ensure that we'd got a human being employed in each of those places to be able to deliver a service, and to make their time available realistic for the pathway that we were going to try and offer. So now on this slide it shows you that we actually have a practitioner in all of the prisons we've talked about. We've got 2 vacancies that we've just recruited to, and obviously, you know, like everywhere else, we have an ongoing kind of people leave and people come, but we're just waiting to have our second member of staff in FOSS. So FOSS is an unusual situation for us because FOSS prison, I don't know if anybody knows, seen it on the news, it's massive prison. It's a 2,000 prison for men. All our prisons are for men, just to say, no female estate at all. We work with just men. Fossway is 2,000 people, and it meant that we had 390 referrals within the first month of it opening, and we nearly drowned. Well, and we have nearly drowned in all the prisons, because I'll talk about referral rates as we go through, but they are high, and we do not even now have anything like the resource to manage the kind of demand. But in FOSS it was exceptional, and it meant that but the one good thing about FOSS was that when they designed the prison, they had expected neurodiversity to be part of something that they needed to think about. So they'd actually put into the contract that we needed 3 staff in there, whereas before nobody had ever defined the pathway, the population, the people, what was needed, and what we were doing was begging and borrowing from other pathways such as mental health. In FOSS, it was sort of expected, defined in the prison population. They were anticipating how many men they'd have with neurodiversity coming into the prison, and so that got built into the contract and it helped. So in FOSS, just as an exception, we've got Jen, who is a speech and language therapist, my first employee. I'm also a speech and language therapist by trade. So that was my first legitimate speech and language therapist post, and we have 2 practitioners in there. We're just waiting for the second one to start. And then alongside me, just not to forget Gillian. Gillian is an occupational therapist, and she works alongside me across all of the prisons at the moment, having a look at kind of sensory needs of our population and supporting around occupational therapy stuff, and helps with working across prisons to make sure that we meet the needs of people in that way. Okay. Just before I kind of do a little bit more about what our pathway looks like, this was my big challenge at the start, and it still is a challenge for me. And I wanted to just put it out there right at the beginning, because I'm not a medical model type of person. You know, it's not really my thing. I wanted to come at it from a positive kind of angle. I wanted to look at it from social aspects. I was aware that medicalising this sort of stuff is not particularly helpful. But I was immediately thrown into kind of a conflicted thoughts around this, because as a health service, one of the expectations is that we made sure that we were offering an equitable offer to the community, and that it was a health service offer. That's how we get contracted in prisons. So I needed to focus on what healthcare would do in the community when I designed what we did in prison. But also, I was listening to the population of people, particularly autistic people, who were saying that the diagnosis is important. And so, as much as I didn't want to set up a pathway that was diagnostic focused, because I'm also aware that diagnostic services have become drowned in the community and have kind of drowned out the more positive, proactive, supportive, needs-based approach that people might feel that they need, because we've got 3-year waits, or all sorts of difficulties with that. I knew we'd be replicating that in prison if we went after a diagnostic model, but I've had to kind of balance it, and I just wanted to describe that. So whereas really the idea of differability, and that was an autistic person on a webinar I watched one day describing the difference between disability and differability, and I liked it. We've tried to balance kind of looking at differences and celebrating differences, but also identifying needs, with the idea of kind of making sure that we do work towards kind of diagnostic confirmation that people might need to achieve the service and support that they need on release. And we found that if we work on a needs basis only and we don't get into assessment and defining needs, that will mean that the person isn't heard, particularly not if they've got a criminal record. The last thing that's going to be listened to is somebody saying, well, I just need a few sensory adjustments, but nobody defining why. So we really have felt quite trapped into a medical model that we wouldn't choose by design, but because that has been led by the people we work with, not just by the fact that we are a health service. We feel like the added value that we bring is to bring that confirmation and that kind of clarification that people need and ask for themselves. So in terms of how we've set up our service and what we do and how we do it, we are an open referral system, and the first thing and the most challenging thing that we've had to do is decide how the hell do we work out who we have in our prisons who might be neurodiverse, and how do we manage the demand, because there's loads of research around this stuff that has extremely high prevalence numbers, up to 25% for people with ADHD. And my feeling, and we'll talk about it as we go along, but is that a lot of that is based on screening, and screening has weaknesses, huge weaknesses. It often screens in an awful lot of things as well as the thing you're looking for. And there is a bias towards the fact that people who are coming into prison are seeking help. They are very legitimately quite disadvantaged in lots and lots of ways. They haven't been heard or listened to. They're wanting support and help from wherever. There are all sorts of reasons why people might be kind of ticking all the boxes when you ask them what they screen in for. And there are also all sorts of reasons why the questions they're asked are a legitimate yes answer, because other things look the same. So screening is an issue in prison in particular, but it's an issue everywhere. But you have to screen, because if you don't screen, you don't know where to start. So we built screening into our reception process, which means that every person, every man who walks into our prison is asked about neurodiversity. We ask some very simple questions. The reception screening process for prison takes place over 25 minutes for everyone who walks through a prison door, and it requires the reception nurse to find out everything from whether or not the person has a history of cancer, to heart disease, to substance misuse, to suicidal risks, and we've added a tiny bit around neurodiversity, being realistic about what you can actually achieve in that early stage of talking to a person. When we take somebody from remand, we're also talking about people who can be in quite a messy state. So people can come in, under the influence, they can come in withdrawing from medications. And so in terms of how realistic we are about getting accurate information at that stage, or even being able to ask it, because there's so much else that we need to do, the reception screen is designed really to ensure that people are safe, that they don't die on that first night. I mean, really, that is the priority. So we have it in our first stage reception screening, but shortly it will be moving to our second stage reception screen, which happens within 10 days of somebody coming to prison. The reason it's not there at the moment is because the second reception screen can be a little bit vulnerable in prisons where we have staffing issues. And so I didn't want to lose neurodiversity into something that wasn't as reliably happening as first stage reception, which has to happen. But I am going to need to compromise if I want it to happen in the way that I need it to happen. It will be a better process when it sits in second reception. So at reception, what I've needed to do to make that work is train all the prison nurses who deliver the reception screening to know what to look for, because they can only ask so many questions. But what I really want them to do is look out, and just have an eye open for potentially speaking to somebody and noticing that there is something that we might need to look at a bit more. And that is all they're asked to do, is record whether or not there is a known diagnosis, which is in their medical record, or whether they suspect that somebody might benefit from seeing us. So it's a very open referral system with no screening at that stage or anything, because it's not realistic at that stage of the process. But what that then does do is pass referrals through to our neurodiversity practitioner, and they take it from there. So if I just click a little bit. Also at that time, just to let you know, what's going on in the prison is that education are also seeing people at that early stage, and they are doing something called an LDD rapid screener, and they've been funded by the government to make that happen across our country, to make sure that we are looking at it from an education point of view. So we have kind of two shots at this, because we ask some questions and we have medical records, but education have a different set of records, and they also have this tool that they will use, and they will tell us if they identify a person through that process that needs to see us as well. We've also got this business of a PERS, which is a prison escort record form, that should highlight something that we know from the liaison and diversion team or from court. Or so if it has been identified that a person is autistic, it should really be on the PERS, because the design of that is to help the escorts to know how to manage a person on the way to and from custody. So that is designed for a different purpose, but it does inform us of things that we might need to know when a person enters prison. We are trying to adjust and adapt we're trying to see if that could do more than it's doing at the moment, because it doesn't at the moment ask any specific questions around neurodiversity, but we think it's an opportunity. And if it did, it could. And when I've been designing this pathway, the entire way through, I've been trying to use processes that already exist, because if you try and create something that doesn't exist on top of the many things that do exist, my experience is that it's nowhere near as effective as building on processes that people already know and use. Okay, so what else do I need to tell you there? Yeah, I think that's that bit. So then within the first 2 weeks, our idea is that we will start working in the prison with our kind of prison colleagues. We have neurodiversity support managers, and something flashes up in a minute, but it's later on in this journey. They started to be employed about 18 months, 2 years ago. The first pilot was 3 years ago. So the whole HMP, the whole estate, HMPPS, the whole estate, prison estate, started to identify that neurodiversity was an issue. And in order to address that, money, for once, additional money came into every single prison to employ a prison support, a neurodiversity support manager. That's a non-healthcare role. It's prison side. It normally sits under learning support, education, skills, something like that. Sometimes it sits under safer custody. The prisons have done it in slightly different ways, depending on which prison it is. I've tried to be involved in all of the recruitment of those people, because it's been really useful to try and make sure that that role is a really kind of holistic, a role that works with healthcare and that kind of looks at the whole prison rather than a very bespoke education role. And it's been kind of developing as we go along. So I think when the jobs first went out, they looked like teacher roles, and it meant that the people that applied were very education orientated. And I would say that we've learned a lot as we've gone along, the prison and everyone around it, about what we need that job to do. But where we have a neurodiversity support manager working with our healthcare counterpart practitioner, we've got a really good thing going on there, because it means that between us we can look at it from a kind of healthcare point of view, but we can look at implementation and working with the person right at reception, induction. The NSMs will normally be around at the induction stage to try and see if they can spot people and work with people very, very, very early on their journey into prison. And again, it's another way of them referring into us, or and we will also, if we start to do our initial assessment within the first 10 days, we will notify the NSM if we see vulnerability and somebody needing support, so we can get something in quite early. In some of our prisons, we've started to do a piece of work on vulnerable people coming into prison and a very early one-page plan. And that would be for a person who either they come in and we know they've got needs and we can immediately share that information. So, and if not, if we spot a vulnerable person where we think that we're going to be identifying their needs, the NSM will pull together a one-page plan and we'll put anything in that we know. And we might ask prison psychology, we might ask offender managers and education to contribute to try and get a brief picture that will mean that prison officers and the people that are working with people every day know what needs to be known to kind of make that journey less difficult for a person from the start. It's really hard, all of this stuff, because of the number of people that come through, because of what we know and don't know. A lot of people come through with nothing known. They just turn up on first day and say, well, everybody in my family's got ADHD and I think I might have, but nobody's ever checked. And most of our referrals are self-referrals. A lot of them, are people just suspecting that they might have a condition but not knowing. What we do is a process of initial assessment, which within the first 10 days, we do part 1. That includes all the screening tools. So we do AQ50s because the AQ10 for autism is ruled out in prisons as being invalid. So we have to use the longer form because it's been shown to not be effective in a prison environment. We've designed our own assessments that expand on that to make sure that we're looking at the needs bit. So how rigid is a person? How much routine matters? Can we kind of identify things that we can do to help early days? And we're doing 2 things. We're identifying needs in order to work towards a safe and well plan. So really all the time, our goal is to work towards a plan that will help the person understand themselves better and everybody else understand them as well. That's always what we're trying to do. Now, diagnosis, if somebody stays with us long enough, is there as an opportunity, but we might not make it because you might not stay long enough. And so whatever we do, we see it as a joint learning opportunity. We see assessment not as us doing to a person, but as us learning together about a person's needs. Interestingly, the people that we get come through with an autism diagnosis often don't understand their needs either. So we often have an autistic person say, I'm autistic, and we can verify the diagnosis, but we can't turn that into a plan for them because we don't know what that means. And as 2 people with autism, no 2 people are the same, it doesn't tell us much to know they're autistic, really. So what we will then still do is assess, if they want to, as a process of learning together, we'll assess their sensory needs, we'll assess their ability to respond to people's facial expressions, we'll assess their social communication, all sorts of things. And that will allow us to do a plan that tells the person and people around them what it is that would make a difference to help them along the way. Okay, I've probably missed important things. It's really weird when you're just talking to yourself, which is what a webinar is. One thing I would say is one of the crucial things that took me a long time to build into the process was seeking consent. It was super important for us to get consent to share. I think we're all crippled half the time by what we can and cannot say to one another. And in prisons, it was particularly difficult because we protect people's kind of confidentiality around their healthcare needs, obviously, for all of the right reasons. None of us would want our healthcare records disclosed to, prison officers, and, it wouldn't have been a thing that anybody would want. Having said that, what we were aware was that most of the people we were meeting did want the prison to know that they'd got a neurodiverse condition, and we hadn't got any mechanism for making sure that we shared things in a way that would work. So we put a lot of work into identifying how we could put that onto the NOMIS flag. And NOMIS is like the prison system that prison officers use and the whole prison service uses, whereas we have a healthcare system that runs in parallel but doesn't communicate with it. So in order to kind of make that work, we have a very detailed consent form that tells people the risks and benefits of sharing. And that meets all the kind of IG requirements for our trust to allow us to say this person has ADHD and this is what it might mean for them in the prison. And that flag goes on their prison system and it follows them wherever they go, but only if they want it to. Now, 99% of the time, people really want it to. But some people have been burnt by sharing information and having it used against them in a prison system. Let's not be naive. For some people knowing they're vulnerable, even, in the prison system can be something that makes them feel more vulnerable. So we do make sure that we ask. When we move on to further assessment, I'm going to talk about it a little bit later because I've got our pathways in a bit more detail. But as I say, that is a joint learning process. We should be gathering information from all our colleagues so that we don't repeat things. We don't want anything repeating if we can help it. I'm sure it happens because communication with each other is always a problem. You know, information sharing is always a problem, but we aim to talk to everybody and get the information that we need. What we don't know, we start to try and find out with the person. Our criteria is working with people who have autism or suspected autism, learning disabilities or suspected learning disabilities, and ADHD or suspected ADHD. There are loads of other things we could do, and there are loads of other things that prison probably should do. But in terms of scope and what is actually manageable and doable and what people have got the qualifications and the expertise to provide, this felt realistic, and it allowed, that was also equitable to the community. So in the community, it would be a healthcare team that would diagnose autism, treat ADHD, and assess for a learning disability or support you with a learning disability. The thing that's missing here is head injury, and some of you will probably be thinking about it. I've got absolutely no doubt that we should have a head injury service in prisons. The issue is that it needs quite a lot of specialism around it. So it most definitely needs things like neuropsychology, neuropsychiatry, and it's expensive, and it has not been commissioned at all. And it doesn't just slot into what we do because it needs some expertise that we don't have. We have slightly extended our offer to include tics and Tourette's for people because we just feel guilty quite often about the little things that crop up, but because mainly it often coexists with other conditions that we're working with, and also the numbers are not so high that it wouldn't mean that we couldn't do the job properly. So we've got a person who is a lead in our trust for CAMS, Children's Mental Health, who helps us with all of those referrals. And as we only have kind of 3 or 4 a year, it doesn't drown, as you know, it's something that we can actually do and we can do well. Fetal alcohol syndrome, we've attended training to help us understand what that might look like for us, but we have not extended our criteria to include it. Same reasons as head injury. I think we can't kind of say what that would then mean for us. It's also very, very difficult to identify in a prison population because you're needing to know maternal history, and for some people we are in contact, for some people we're not, for some people that's a difficult subject to talk about, but it is something that we've got in mind. And when we know that that is something that's possible, we have that as part of our formulation in the back of our mind. Just gonna hide some photos because I can't see my bit. Right, reasonable adjustment. So when we're doing the assessment, as I say, the whole point is to work towards a reasonable adjustment plan. Sorry, this bit is just something cropping up over, and it's not going to let me do that without. Oh, okay. Yeah, I can't see it, but I know what we do. So the whole idea is that we're identifying a plan, really. So we do things like safe and well plans if you're a person who is presenting with particular risks. We also do an autism advocacy plan, or all manner of versions of. So basically a personalised plan that says what we know about you and what that means. We try and highlight your strengths, and we also highlight and how they can be used to make life better for you, which is very, very challenging in prison. So to do any sort of strength-based work in prison is very, very difficult because the opportunities to use your strengths and the things that comfort you are very minimal because you have very little available to you. And we just have to be realistic. The whole reasonable adjustment conversation in prison has to be realistic. It's what's reasonable. You know, there are lots of things we cannot change that conflict with security arrangements, but what we will try and do is anything that we can. We work with our diversity and inclusion colleagues to look at considering it in the same way as we would a physical disability. So if something like ear defenders are required in a workplace where it's busy and noisy, they can be provided through the prison in the same way as a walking stick would be provided. So that has been a lot of work to try and kind of look at what we can do that then will help the prison decide what can and cannot be offered. The neurodiversity support manager's job, they'll often be the link person with that. Sometimes they have their own access to resources. It's all quite different according to how it's been resourced in different prisons, but that's what we're aiming to do. And then in terms of interventions, sorry, let's go back. We do all sorts of things. So if we get as far as working out that we've assessed you, and like I say, for ADHD and autism, and learning disability is slightly more challenging because we need a WACE carried out by a clinical psychologist to do that job, or a forensic psychologist. We've got psychology, but it isn't attached to our pathway. And so thankfully, we've got a psychologist who helps us sometimes with this work, and the demand isn't massive. but our forensic psychology colleagues in the prison itself, who are focused on risk really, and risk avoidance, and supporting around that, they will sometimes assess you for a learning disability, but often won't have that in their remit. And so you can find that you've got a person who a learning disability has been suspected for years and years and years and never defined. So we do try and pin that down, particularly because learning disability is one of the things where if we identify that, you will get a different offer on release. For autism and ADHD, sometimes there's not going to be a lot of difference to what we can actually make happen or change in terms of service provision. We can make a lot of difference in terms of how people understand you and how you understand yourself, but there isn't a load of money thrown at these things to be able to make it different. With a person with a learning disability, we can start to try and look at the support system around a person. We can refer into community learning disability teams. We can look at this kind of supported living that somebody might need. So it does make quite a big difference if we get that right, but we will only get any of that if we diagnose a learning disability properly in the prison setting. So we do a full diagnostic offer for all of those things, but often people don't make it to that point in their journey. If they do, and if they've got a diagnosis, we start to do some of the intervention work that we do. If they don't make it, we are running a safe and well plan in parallel so that they get that. As we learn about their needs, we include their needs in a plan that they can use while we're working towards diagnosis. So if they're released ahead of time, they still will have a plan that will help them understand what we've done and what we've learned together. If they do have a diagnosis, we have some really lovely psychoeducation packages that we've tried to pull together. We've used the men to kind of inform us. We've tried things. Some things have been catastrophically disastrous. So we tried running, I don't really even know what I was thinking, but we based a load of sessions on the Recovery College model that had been developed in our trust. It was a brilliant thing that had been written with people with ADHD, delivered to groups of people outside of prison in Notts. When we tried to run those groups, and I tried myself a number of times because I try to do things, not just tell people to do things, but try and see if they work. They were catastrophic. So 8 men with ADHD in a room in prison where there's not the right kind of facilities, equipment, tables. I can honestly say they were complete and utterly chaotic, and we didn't manage to do any of that group work. So we tried and failed with that. So what we've got is 30-minute psychoeducation slots where we've broken that right down. So we do ADHD and sleep, ADHD and relationships, and we ask the men what is the priority for them. What is it that's really difficult for them? So we don't have to deliver everything. Some of them aren't interested in some of the stuff. And we try and kind of then do that 1-to-1, maximum 2-to-1. No more, because it's just too difficult. We also do autism psychoeducation groups, which we do offer kind of up to 3 or 4 people together, keeping it small so people aren't intimidated by that group environment, but providing the opportunity of learning from one another, which people who've attended those have found them very anxiety provoking, because being with anybody else in a group is anxiety provoking, but they have all appreciated. We've had a lot of feedback about how useful it's been to hear other autistic people talk about similarities and differences. And so we're still quite keen on doing that in a small group situation. Our interventions are all working towards kind of planning release. So they're working towards what a person's going to need when they leave. And we try and have that in mind all the way through. We have been trying to look at peer support, mentoring, peer champions. We're nowhere with this at the moment. So it's our next priority for 2025. And a lot of the work we've done has been all about making sure that we are preparing for a person getting back into the community. So we try and have early MDTs. If somebody's been working with multidisciplinary team meetings with a team that knew a person before they came into prison, huge challenges here, because often we don't know if the person's going back to where they came from. The teams that they were working with quite often close the referral because they've gone into prison and, they don't keep a referral open. Lots of issues around trying to make sure that we can prepare for somebody coming out in 3 months' time, or because we know that the people that we're releasing are going to need a lot of prep time, but what under pressure services are doing is not being able to allocate resources to things that aren't a problem right now. So trying to get that proactive work happening. Sometimes we succeed, sometimes we don't, but we're always trying to make that happen. And then we just concentrate on trying to get a smooth transition of care. We work with our Reconnect colleagues 12 weeks before release if we can. We support them to do that. Okay, so I've talked about support managers. these are other things that we would do. So looking at kind of whole areas of projects, so segregation units, looking at when people are segregated, can we train that whole staff team to understand what it's like to look after somebody with neurodiverse needs in segregation? Wing training, you know, trying to get experts in amongst all of that. And then also in prisons, we have something called the ACT process, and don't ask me to define what the acronym is because I can never remember. But basically it's the way in which we protect people when they are at risk of self-harm or suicide. So if people start to be at risk, they go into an ACT process, which means that the prison monitors them and has staff on different levels of observation. So they will be watching them, keeping an eye on them. And in that ACT process, what we've been trying to do is develop ways of trying to keep people out of ACT. If they've gone on to the ACT process once, how can we try and avoid that happening again? What were the things that led them there? Is there anything around their neurodiversity? Is there any distress or anxiety that could be reduced by doing things better so that we're not in and out of ACT processes? So lots of stuff that's targeted at particular prison processes or places that is designed to kind of make life better for people. Right, so quick scoot through these. I've already talked about this already. This was the big challenge of how the hell we get information sharing. Nationally, this is still going on. There has been some work done that means that we've made a step forward with this. I think there is an agreement that we should share now, but healthcare teams will be very reluctant because they will be very worried about losing nursing pins and things if you share things that you shouldn't share. So there's still an anxiety around information sharing. Just to say, one of the issues, I'm not going to go into this in a great deal of detail, but I have included it in the slides, all the links, so that you can have a look later. I came from a commissioning background. I've worked in crisis teams. I'm 25 years into doing this kind of work. I've done all sorts of jobs. And I came last time, my last job was working in avoiding admissions to hospital for people with learning disabilities and autism, and trying to get people out of long stay hospitals with autism and learning disabilities, which we call transforming care. So transforming care was government policy that came in following Winterbourne View and the abuses that happened in a secure hospital environment. And the end result of that was it's our obligation to keep people local in their community and away from secure hospitals unless they require secure hospital treatment for a treatable condition. So in the past, we were sending everybody with a learning disability into a hospital environment if they got a bit risky or tricky. The guidance now is that we shouldn't be doing that. When I came into prison, my major concern was that it hadn't kept up with this community focus on keeping people local and at home, because people were not thinking about prisoners at all. So if you'd ended up in hospital, we knew what we were doing with you. But if you ended up in prison, which can be a pretty random thing as to whether or not you are diverted from prison or not, you might have done similar risky things, and you may or may not have ended up in the criminal justice system or in a hospital setting. What had been dealt with in a hospital setting hadn't been dealt with in a prison setting. So we'd got a lot of people that were potentially in prison who could have looked exactly the same as somebody who'd end up in a secure hospital, but with none of the protections around what would happen when they were released, and none of the planning and none of the support. So I did a lot of connecting with the local ICBs and to kind of talk to people about, can we start to include prisoners on your dynamic risk registers, which are registers they keep for people that are going to come back into area and require everything. So require something from housing, something from, you know. So now there's no guidance from NHS England to have to include prisoners. So there's no mandated reason why they would. But the reason they would is because these risky people do come back into area and they do sometimes need all of this stuff doing. And so it's either a know about it or don't know about it and deal with it when they land on your doorstep kind of situation. So this is the way I tried to sell it. And we have been doing that work. So we've been having something called care and treatment reviews for people that we think are at risk. And that has brought in ICB colleagues to say, right, can you please start to think about these people who have happened to end up in prison, but are autistic with loads of risks of escalating offences? And can we please try and plan for them in the way that we would if they'd been in a hospital? So a lot of our pathways are set up to try and kind of make sure that we are doing what we would do if a person was in the community. It also was a challenging thought for us to make sure that we didn't send people to hospital from prison if they got a bit tricky. So what we were finding is people overrepresented in segregation with a learning disability and autism. And the first answer to that was, right, I know, we'll gatekeep them through from prison to hospital now, and that hospital will deal with it. Although it's a challenging way of thinking about it, my view has been, it is this idea of what is least restrictive. Now, you could argue a hospital is going to be nicer than a prison. You could, if you wanted to. My view is that they've got a sentence with an end date on it. So for somebody who's serving kind of 3 months, 6 months, a year, if you are transferred to a hospital with a learning disability, you could find yourself 10 years in hospital there because your sentence is on hold until you prove that you're well. If you've been sent to hospital just because you've got a learning disability and risky behaviour, you may not prove that you're well, and therefore you may not be released. So it is a kind of consideration of whether or not you should or shouldn't be in prison or hospital, but we've been trying to kind of follow the same guidance as we would if a person was in the community. So I've talked through lots of this. I hope I'm doing okay for time. Yeah, 15 minutes is fine. So in terms of our pathway, just to show you the difference between when we're working with a person with different kind of conditions. So for a person with an ADHD diagnosis, if they come in with a diagnosis, they go straight to caseload. Referral rates can be as high as 10 a week, can be as low as 2 a week. Different prisons, different referral rates. Some prisons only take from other prisons. And you also get different sorts of people if they're coming from different prisons, because they might be known than if they're coming in straight away to a remand prison from the street on a first sentence. So for ADHD, we'll immediately put a person onto a caseload. And we'll carry out a review and we'll put a plan in place. We're trying to get people treated if possible. For ADHD, frontline treatment is medicine. Doesn't mean that coaching and other things aren't useful, but we do need to make sure that people have the nice recommended treatments that everybody else would have. So we developed our pathway with community in mind. We made sure that it married up to all our local partners so that when we refer on, there's no glitch between our process and their process. We don't want any, well, that's a prison diagnosis. We don't do it like that out here. We don't want anything that's going to get in the way of our men continuing their treatment and care. So and it includes a screening process, it includes the DIVA diagnostic assessment, and just out of interest, we always kind of communicate with family, so where we can. So about 95% of the time we'll contact a family member and talk about what the person was like before all of the mayhem of their life, happened. That's an incredibly important part of the diagnostic process, because often differential diagnosis is really difficult. We focus on differential diagnosis and comorbidity. We're not looking at somebody just having ADHD and narrowing, taking a narrow view. We're understanding that people have been in care, they've had neglect, they've experienced abuse, they've had trauma. We understand they might have a diagnosis of a personality disorder, which may coexist or may be considered, because somebody's been so dysregulated, impulsive. We're constantly kind of trying to have a look at how these things exist and coexist together. We may start to do a safe and well plan quite early if risk is the primary kind of thing that we're needing to look at. And that can make immediate adjustments, like somebody might need more gym time, or we might need a particular workshop that they need to be in that is more suited to being physically active. We are formulating all the time. So we're kind of looking at what we see, looking at what we see on the wings, looking at what we see around the prison when we see the person, living their lives, and trying to work out whether that marries up to what the person's telling us. And what we've learned. It's quite a tricky process. ADHD is trickiest because it comes with controlled drugs on the end of it. So just to be honest and realistic, it's a prescribed amphetamine that you have if you have ADHD. And so we have to be careful in a prison population, because drugs are currency, things that can be diverted or sold. People will do it for their own survival. So we have to be realistic about the fact that some people might be seeking the end goal here in order to get a prescription drug that they can either sell or take to feel better, and there's no judgment attached to that. We just have to be realistic about what we do. If we get to the end of the diagnostic process, you'll see your psychiatrist. The psychiatrist will then confirm or challenge the diagnosis, and you will start on a titration care plan. We'll review you every 3 months, and we'll make sure that you are responding well to medication. We'll make tweaks and changes. We'll check on you physically, and we'll put you into, you'll be offered psychoeducation if you want to learn more about your diagnosis. What we find is people treated respond better to psychoeducation than people that are untreated, because there's a degree of focus that's required to do psychoeducation. So it's in our interest to treat and then look at psychoeducation for people who can focus. And we start the process of referring on to specialist providers and shared care agreements. For autism, it's a very, very similar process. I won't go into it, but we use a big range of assessments, not just focusing on diagnosis, but focusing on learning how a person copes and doesn't cope, learning where their strengths are. And we build that into a big report at the end that says everything we've done together. And people find that incredibly useful to take with them, to share with their offender managers, to inform prison processes. The thing we have to try and avoid with all of our referrals is referrals that come through the court processes and parole processes. So the pressure we have to resist is solicitors, and again, no judgment here. I understand why a good solicitor would be looking for a timely diagnosis, but what we cannot have is people jumping the process because of sentence defence kind of related requests for assessments. We have to remain clinical needs led. Otherwise, we would absolutely drown. And when parole or courts are asking for assessments, they're asking for them yesterday, so they're asking for a report within 2 weeks, or we can't operate a service that runs like that, and it's not in our contract to do so. So as frustrating as that is for our offender managers, and I totally appreciate why, if it comes through a court process, they need to seek that privately so that it's timely and in line with sentence planning. If it coincides with the fact that we're already assessing a person, we're not going to be difficult about it. We'll do the best we can. But what we cannot do is keep prioritising according to kind of criminal justice needs ahead of clinical or patient-centred needs. So just a quick case study. So I've got 2 quick case studies and then we're nearly there, I think. So this is the sort of way that what we do might impact. Do you know what? I'm going to struggle with this because I still have photos in front of me that I can't get rid of. Let me just see. Oh, it might be okay if I'm not clicking on it. Right, okay, so this is a case study. I've asked all my practitioners to kind of start to pull together people they've seen, things they've done, and to kind of explain what difference it might make. So we had a young person, a young individual in their early 20s coming into one of our prisons. They've got an indeterminate sentence. So you'll know about these sentences. So we have IPP sentences that go on for ever and ever and ever and ever, and they're, we've had loads of issues with people where those don't get overturned. And just to say, I'm sure people know this, but neurodiverse people are massively overrepresented in IPP sentences. They're hugely overrepresented. So this was a person who'd been sentenced at 16. They had come from living in a group home with other children. They'd experienced lots of domestic violence. There'd been loads of family challenges. Mum had struggled to cope. All their siblings were placed in care. No diagnosis because, common to many of the people we see, chaos had reigned in their lives, so everything was all about kind of dangerous home life, getting them into a safe space, and then behaviour that feels like it was responding to being in care and everything that had happened in the early days. There was a diagnosis on record for emotionally unstable personality disorder. I won't go into this too much because it works both ways. So we see a lot of people where that diagnosis has been added to record for a person who's experienced trauma. I've got a lot of different feelings around it, in terms of sometimes we are seeing that people with ADHD, it may be that actually trauma and EUPD is more relevant for a person than the neurodiverse diagnosis they've been given. Sometimes it looks like it's comorbid and could coexist, and sometimes a neurodiverse condition feels like it's been missed entirely because of the chaotic, traumatic experiences that a person has had. And it can be just really difficult to pull that apart. This person had been treated with medication, quetiapine, for hearing voices. So it's an antipsychotic that's been used, but it got stopped when the voices ceased because people thought that it was anxiety and not psychosis. They'd been struggling with understanding the rules in the improved premise, and that had led to recall. For people on IPP sentences, indeterminate sentences, recall, it's almost impossible to stay out of prison. There are lots and lots of reasons you might get recalled. And I suspect that that's why some of our neurodiverse people don't get off them, because it's not just that you need to prove to parole that you're ready for release, it's that you need to stay out and stick very firmly to quite restrictive conditions that if you don't understand them properly, it's really easy to breach them. So this person had moved between prison to prison to prison to prison with little support for neurodiverse conditions. They had a long, probably because there wasn't a service in the prison they went to, they had a long history of not being released without proper neurodiversity or mental health support. Hold on a minute, that's making me do something not flick right. We contacted the family to understand the childhood history, to find about their emotional struggles. We referred to mental health team for voice, hearing and anxiety concerns. We started our work. So we started ADHD assessment, we started working on anxiety and ADHD so that we could deal with what the needs were whilst finding out whether or not we thought ADHD was relevant. While we're doing our assessment, we start to notice that this person's quite rigid. They're really struggling with the questions. They seem to be really, really concrete in their thinking. And so we start to think that maybe autism is something that we should also consider, and we go through that diagnostic process and we confirm ADHD and autism by the end of our process. And we start to shift the process from looking at anxiety to looking at autism-specific support strategies and anxiety relating to neurodiversity. And we start to tailor the support to social understanding and emotional management and all the things that might be more relevant to that diagnosis. This information is shared with parole, sentences reconsidered, and it leads to a favourable outcome. And this person is finally released with a comprehensive care plan, and their support is properly defined to the community, looking at the support they'll need to stay out this time round. So what worked? We immediately led to better relationships with officers and prison staff when people understood the person better. The medication that was inappropriate was stopped because it was found that the anxiety was anxious thoughts, not psychosis. That's really important. We don't want people on medications they don't need. We were able to personalise that support and improve understanding and emotional regulation just by the person taking a bit more control. We were able to structure some of the activities to include social skills awareness so that they were getting to do things they were good at and learn at the same time. And we were able to shift from general anxiety management to more specific approaches that work better for that person. And we carried on kind of focusing on how to manage those communication challenges. The things that could have worked better are just the lack of services that are available. That had led to things going wrong quite badly for this person. Lots of social communication misunderstanding, people being understood to be rude, aggressive, poor eye contact, no empathy, not apologetic. The transfers were meaning that we couldn't get any consistency of support. It kept moving, so we weren't able to get to the end of he hadn't got to the end of any sort of process. The expectations and rules of the approved premise, there'd been no adjustments or adaptations to mean that this person understood what was expected. And so it felt like a bit of a setup to fail type of scenario. When the person was supported post-release, more support was needed, and there was more support needed around rules and boundaries. But the current status is this person is out. We're managing to be supported and being supported through community services post-release. And so what would we change? Faster identification in the assessment of neurodiverse conditions, focusing on individuals to explore and diagnose neurodiversity. We need better training for healthcare teams to spot early signs of autism and related conditions. And we need more consistent care between prisons. At the moment, it's a lottery as to whether or not you'll get any support in a prison situation, depending on what they've got. Right, there's me thinking I wouldn't fill the time, and now I'm going to run over by about 5 minutes. So I'll go quickly and get to the end so that it's time for questions. I have talked to you about all of this, so we don't need to go over it again. There's for learning disabilities, we're doing exactly the same thing, but what we're quickly focusing on is vulnerability. We might go straight into safer custody processes for a person with a learning disability because there is a vulnerability attached to this in terms of prisoners will often spot a learning disability before anyone else in the prison does. It's the thing that can be easiest missed, especially for people that are masking and trying to hide their vulnerability and not letting people know. A lot of the people we work with a learning disability in prison know prison, so they can seem capable in prison. So therefore they might look like they've got the right vocab in prison. So our focus is on finding those people quickly before prisoners do, and trying to work out what it would take for that person to be looked after and supported well and safely. We carry out annual health checks that are mandated. So we need to know if you've got learning disabilities because we're going to do a top to toe check on you. NHS England requires us to do that to make sure that you don't, as the LEDA reviews nationally have shown, die too young just because you aren't able to identify your healthcare needs. I'm not going to do that case study, but you can read it later. So this is everything else. So we work with our colleagues on other pathways to help with assessment and treatment. We support in the SEG unit, we support ACT and prevent ACT. We do group work in the Wellbeing Centre. We're trying to do things like, we've got a group that is around checking in with people that are vulnerable, because we haven't got specific things we need to do, but we just need to have eyes on people and give them an opportunity to be able to tell us if they're scared or worried. So we've got all sorts of things like that going on where we can. We haven't got that in every prison. Some places haven't got a Wellbeing Centre. We're starting patient forum work and I'm sorry we're using the term patient, because we don't consider people patients really, but we're in a really medical model in prisons. So we're doing forum work where we're asking people what they think and what they need and what they know. We had a volunteer phone up all of our people to ask them what their experiences of our pathway, and we are working our way through finding out what they said, what they need, what they'd like to be different. And we did that in all 8 prisons. We had over 100 replies. So this helps, this helps us. And we're working with other people who are kind of advancing the agenda locally and nationally. So, all of these different people are, the more we can join up, the more we can make better outcomes for people. So our next steps, it's this stuff that we've been weak at. So co-production, we'd really like to get to a place where we train with our neurodiverse people in prisons. I've co-produced some training and delivered training with an autistic man in Lincoln once. But it's having people that stay long enough in the prison on a sentence to be able to facilitate it, make it work. But our plan is to develop roles for people to be kind of volunteer, well-trained volunteers who can support other people in the prison. The NSMs are doing that work as well. So they are identifying their champions on wings. And in some places that's working better than others, but that is really what we want to do better this year. We want to do more training alongside our colleagues. We're wanting to create a load more accessible information. A lot of the stuff that we give to people is completely inaccessible. It needs to be better and easy read. We want new treatment options. We're developing a package for social anxiety and autism, and little tweaks where people have said, this is what I need. Can you help me with this? And we're starting a piece of research with Derby University to have a look at our ADHD pathway all the way through to community to see whether or not it works. It's going to be a horrible thing if I find out it doesn't, but it might. So we're going to try and find out about the journey. And then this is my final slide. So the whole idea really would be to get to a place where we've got a prison that is kind of successful and safe for all people, in which case we wouldn't need to be quite so focused on what healthcare does. And I think this is the case for all of us. If we had a neurodiversity friendly environment, we wouldn't need to do a lot of the diagnostic stuff that we need to do in the community or in prisons, but we don't. And so whilst it's not neurodiversity friendly everywhere you go, and it's biased towards a neurotypical world in prison or out, then we feel that it's our job to make sure that we explain how that person can cope, fit, and what people need to do to adapt to meet their needs. But also the person needs to understand. We talk a lot about masking and celebrate and the negative side of masking, but there is some masking and managing stuff here about explaining to a person, you can choose, we can either explain to, or it's normally and both. We need to explain to people what they need to do to accommodate you and your needs, but also if you want to go into an environment where we know it won't adapt well, you're going to need to decide how much you are going to need to mask and manage, and whether you want to or not. And because this needs to be something that people are empowered to make a decision about. Masking isn't always a negative thing. It does sometimes allow people to do things they want to do in a world that is still biased to neurotypical people. So yeah, we're on our way up that lovely tree, but not there, is what I would say.